Thoracic pedicle screws are not difficult. The thoracic pedicle screw insertion has a steep learning curve due to its complex anatomy, and literature on pedicle screw insertion in typical thoracic vertebrae in non-scoliotic spine is scanty. The studying learning curve of a surgical procedure is important to find the problems faced by a novice surgeon and find its solution, and to set guidelines for training and educational purposes. The aim and objectives of this paper are to delineate the learning curve in thoracic pedicle screw placement and to evaluate safety of freehand technique in non-scoliotic thoracic spine. It is a prospectively collected data at a single institute by a single surgeon in 92 patients with 735 screws inserted. Thoracic pedicle screws inserted for stabilization due to any pathology except non-deformed spine in typical thoracic vertebrae, excluding revision and deformed spine. The standard freehand technique described by Lenke was used, in which thoracic transverse process to transverse process exposure was done, followed by inferior facetectomy and removal of the superior facet cartilage, articular cartilage, then the removal of the cortical starting point with a nibbler. Following this, gear shift probing was done, in which first 15 to 20 after inserting the probe, it was feeled for any perforations with a feeler, and only after that the probe was inserted further. The palpation and pedicle length was measured. Tapping, repalpation and screw placement was done in the similar direction and angulation in which tapping was done. All cases were assessed by C-arm after all pedicle screws inserted in all patients, and the parameters assessed were perforation incidence, the type of perforation, that is medial, lateral, superior, inferior, the grades. Grade 1 would be less than 2 mm breach, grade 2 would be 2 to 4 mm breach, and grade 3 would be more than 4 mm breach, with location of the vertebral level and which perforations were critical or symptomatic. Assessment of learning curve. All patients were divided into 4 quartiles, with the change in parameters noted in each group were used as a standard for the others. Standard statistical analysis was done. The demographics showed there were around 53 males and 39 females, with infection and trauma being the largest contribution to the cases. The perforation incidence in quartile 1 was approximately 40%, which significantly reduced in quartile 2 to 20%, which was statistically significant, and which also showed further improvement in numbers in quartile 3 and quartile 4, but those weren't statistically significant. The most common location of the perforation in quartile 1 was medial, which also statistically improved in quartile 2, and also showed improvement in quartile 3 and quartile 4 in numbers, but which didn't have any statistical significance. And similar results were also found in perforations of lateral, superior, and inferior, respectively. The grade 2 and grade 1 were approximately 60 and 30 in quartile 1, which reduced significantly in quartile 2. The critical perforation also were less in the first quartile, and which further decreased and was statistically significant in the further quartiles. The highest number of perforations were found to be in thoracic T4 level, and the lowest were found to be in T9. Based on our analysis on the perforations that we found out in medial, lateral, and grade 2 perforations were mostly due to inadequate exposure, then not following the gray shift probe method, not feeling properly, in apprehension of the surgeon, not following the standard anatomical landmarks, in an attempt to get accurate placements, further perforations were noted. This is a case of 34-year-old female with difficulty in walking since 10 days, neck pain, and when UMN signs being positive, was reconstructed with decompression and fixed from T1 to T4 levels. This is a similar second case of 24-year-old female with history of back pain with band-like sensation over the chest since 10 months with UMN sign positives, which were cox spine, which was fixed similarly. In our recommendations, we recommended the novice surgeons to study the dysplastic pedicles preoperatively, Have adequate exposures. Choose the anatomical landmarks strictly as shown by Lenke. Follow the surgical technique. Use filler at every step. Follow the strict rule gear shift probe. Accept the acceptance of entry point and direction regulation of screw placement. And always check with one AP and lateral post intraoperatively. Similar literature showed that Modi et al. And Kim showed similar result with freehand techniques which were comparable to our study. In summary, for mastering the art of inserting thoracic pedicle screw, a novice surgeon must understand the problems encountered in the first 50 cases and the reasons behind these problems. Then follow the recommendations that we have enlisted, and to enhance the surgical skills, perform in an academic hands-on workshop following these guidelines provided above. Thank you.